Good morning, everyone, for this new episode on Massive Hemorrhage Protocol. This is TransConnect March 2023, and I'm Dr. Mohit Chaudhary. So, I'll be taking you through this topic, which is very important both clinically, in patient blood management, and in blood transfusion medicine. So, there is a thing that every 1 minute delay in receiving a first packed red cell in the bleeding trauma patient is associated with a 5% increase in mortality. So every minute counts, and that is why this episode is very important. Many a times you would have heard the terms massive hemorrhage protocols. Also, you might have heard massive transfusion protocols. They are used interchangeably, but a better term would be a massive hemorrhage protocol because it does not just involve giving packed red cell or blood components to the patient. It also means that you are giving some drugs like tranexamic acid. You are trying to control the temperature. So basically, what you are trying to do uh, is control the hemorrhage. So a better term would be a massive hemorrhage protocol. But for the sake of this lecture, you might come across massive transfusion protocol as well. So they both are used interchangeably. So what we are going to do is we are going to cover it into 7 aspects, which are the 7 T's of massive hemorrhage protocol, which involves trigger. What is the trigger point? When do you trigger a massive hemorrhage protocol? The team, which team is involved, how we have to go about it, what is the role of transfusion medicine, testing, what are the tests that we employ, how we employ the tranexamic acid to prevent bleeding due to trauma, temperature monitoring, what are the targets that we should achieve before we should terminate it. So what are the targets and what is the termination or the endpoint. So these 70s will essentially cover the whole of massive hemorrhage protocol. So let's go by these terms one by one and how we are going to go about in our setting in massive hemorrhage protocol, what is the code that we announce and how we go about it. So what is the definition of massive transfusion? You can see the replacement of one blood volume within 24 hours. So when we deal it in 24 hours, you can say one blood volume within 24 hours or 10 units of whole blood in 24 hours. Also, exchange transfusion in neonates is considered as a massive transfusion. Then there is a dynamic massive transfusion definition, which says that replacement of 50% of blood volume within 3 hours, 4 units of blood within an hour, with an ongoing requirement, or loss of 150 ml blood per minute. So all these definitions generally you can see it is a sometimes it is clinical, but just to reiterate the fact that massive transfusion you need to have one definition, it can be a 10 units in 24 hours. So that is a thumb rule we follow for the definition of massive transfusion. Which are the clinical situations for massive transfusion? We all know trauma is one of the clinical situations where a massive transfusion may be required. Generally, penetrating or perforating wounds of chest, abdomen, pelvic fractures, crush injury, road traffic accident may lead to a massive transfusion. Then there can be a surgery which has gone wrong. It can be a liver transplant, major surgery like a liver transplant, resection of major tumors, cardiovascular surgeries. Another area is OBS, where we have APH or the postpartum hemorrhage, ectopic pregnancy rupture, placenta previa, etc. In medicine, it can be a GI bleeding or a warfarin overdose, or in hemophiliacs. Then in neonates, it can be an exchange transfusion or a neonate on ECMO, cardiopulmonary bypass. And some old patient or frail patient with comorbidities can also require something like a massive transfusion. So what are the management strategy? How do we want to go about for massive transfusion? What are our goals? So what we want to do is we want to restore the blood volume to maintain the tissue perfusion and blood pressure. So once we have the blood volume, the tissue perfusion will be adequate and an adequate blood pressure will be maintained. Obviously, the oxygen carrying capacity will be restored. And then we have to also treat the surgical source. If there is some source of bleeding, we need to treat it. And we have to correct the trauma-induced coagulopathy by use of the various blood products like FFP, platelets, cryoprecipitate, and most importantly, we have to also correct for hypothermia, which may happen in massive transfusion. So decision to transfused blood should be based on the transfusion trigger. There are multiple thresholds on which we can transfuse the patient. The rate and magnitude or the trajectory of the blood loss, the degree of the cardiopulmonary reserves, if there is an operative intervention, if the patient is on anticoagulant and still wants to go for a major surgery, you need to anticipate that the massive transfusion may be required, and the oxygen consumption per se. The type of the component to be transfused depends on the assessment of the clinical status of the patient. So coming to the 7Ts, the most important 7Ts of massive transfusion protocol. Please be informed that massive transfusion protocol is MTP and it has got another acronyms as well. So you can, for the purpose of this lecture, it is MTP, MHP or massive transfusion or massive hemorrhage protocol. So what are the 7Ts? Let's come to the 7Ts. They are trigger, when do you start it? Team, second is team, third is testing, fourth is trauma and tranexamic acid, fifth is temperature, sixth is target, and seventh is termination. So let's go by these one by one. So what are the trigger points when we start a massive hemorrhage protocol? So this can happen when the patient has not arrived to the hospital. So it can be a pre-hospital thing where you get a call in your ER and they say that there is some kind of an injury, suppose say a penetrating injury or a fall from a three-story building or something like that, and you're anticipating a huge blood loss. So patient can go in hypovolemia. It can be an intravascular blood loss leading to a hypovolemic or a hypovolemic shock. So that is when you anticipate a massive hemorrhage protocol. So initial assessment, when the patient comes to the hospital in the ER, then the clinical judgment is imperative. You will see there are basically a lot of clinical decision tools, the resuscitation intensity with which you are doing, and some pitfalls where you would require massive hemorrhage protocols to be activated in some special conditions. So when the patient is with you and he has arrived in the ER, you would like to do some clinical judgments. There are some indexes or some decision tools which can actually tell you whether the patient is in shock or patient is okay. So that is the shock index should be greater than 1. There is a delta shock index, there is a RABT score, etc. Or if the patient is not a usual patient like an old patient, an elderly patient or a neonate where the patient has had a fall, or the patient is on anticoagulants, he's on warfarin therapy, he's on dual antiplatelet therapy, all these things make them vulnerable for blood loss and you need to anticipate these things. You have to reverse the anticoagulant effect first. Then medication that may blunt hemodynamic response like beta blockers. So all these things you should keep in mind when you are initially assessing in the ER. Then when you start your resuscitation, you need to see your resuscitation intensity, whether the patient requires more than 2 units of packed red cell or not. So we can use a more objective MHP triggers, which can be like, suppose like a dynamic massive hemorrhage protocol definition we discussed, where a critical administration threshold is greater than 3 RBC unit in 1 hour. So you need to remember that if that is happening, you can anticipate that it can be a massive hemorrhage protocol that you need to activate sooner or later. A shock index greater than 1, the ABC score greater than 2 with penetrating mechanism of injury, systolic BP less than 80, heart rate greater than 120 or a fast ultrasound, or a RABT score. So going deeper into these are few of the scores which can be dealt with. This is the assessment of blood consumption score or the ABC score, which if greater than equal to 2, you can trigger a massive hemorrhage protocol. So what does ABC say? It just says that your systolic BP, if it is less than 90 or not, heart rate is greater than 120, and if there is a penetrating mechanism of the injury, or a positive fluid on the abdominal USG, right? So any of these, if it is positive, it is 1. If it is negative, it is, or no, it is 0. So score of 2 predicts 38% of need for massive transfusion, whereas score of 4 predicts 100% need for massive transfusion. So it's a ready tool available. You can use this as your score, that is the ABC score, or you can have a revised assessment of bleeding and transfusion score, where you give 1 point each for all these things, which can be a shock index greater than 1, pelvic fracture, positive fast, or a penetrating injury. So all these scores are just a tool for you to understand that, okay, these things are going wrong and you may require a massive hemorrhage protocol. While you are doing the resuscitation, if hemorrhagic shock, that is the hypovolemia due to intravascular volume depletion, is not very obvious, you can consider the resuscitation intensity. So patient who require 3 units of any combination of crystal oil or blood products to maintain adequate perfusion are considered to have high resuscitation intensity, which predicts higher mortality and should be considered for activation of MHP. So how do we match these? So we know that we have to give combination of the various blood product. So what ratio of blood products is advocated is very important. What you follow in your system is should be laid down. So we follow a 1:1:1 or a 2:1:1, where 2 stands for plasma is to red cell is to platelets. So if you are giving 2 plasma, 1 red cell, 1 platelet, or you can give each in 1:1. So like 6 units of RBC, 6 unit of RDPs, and 6 unit of plasma. So you can do have any of these combination, but favorable is 2:1:1. I mean, but you can have your own protocol. So who can initiate this MHP or MTP? So it can be initiated by anesthetist who is dealing with the patient, the surgeon, the primary physician who is in charge, the blood bank in charge once he comes to know that there are a lot of units being initiated, lots of units being issued, and the clinician. Also, sometimes the sister who is very vigilant, or the OT in charge of, or the OT sister who's there with the patient and is seeing that lots and lots of units are being procured, can activate a massive hemorrhage protocol. But this needs to be told to the clinician who's actually performing the surgery. So you have to lay down this kind of a policy, and it should be there in your system as to who can activate a MHP and how you are going to activate the MHP. We are going to talk about this a little later, how we do it in our setting, and obviously you can take a clue from that. So next is your second is team. So your team is very important, and it's not just your team. It has to be a collective multidisciplinary team which acts together, works together, and tries to find the patient uh, healthy only if you work together. So what you're going to do is there should be an extended team which should include an emergency team. So if an emergency team knows that there is a call that has come and the patient requires blood transfusion, which can be a massive hemorrhage protocol, what they can do is they can give a head start to the through the blood bank, and they can start preparing, thaw the FFPs, and activate their own team within, so that we are well prepared when the patient actually arrives in the ED. We all know every minute is crucial, so you need to prepare yourself, gear yourself, and your team, and there should be specific roles assigned for each of the members. So if a technician or a tech is arranging the blood, then there should be another person who's going to thaw the FFP, the other person who's going to make the compatibility sticker, do the cross match, make the pack, and one person who is liaising with the emergency or the patient wherever he is. So every minute that you're going to save is going to save the patient life. So that is very important. You have to prepare your gear, and your team should be very competent, very fast, and very proactive. So what is the role of blood bank here? The degree of urgency for transfusion should be accurately conveyed. If it is conveyed pre-hand, it is obviously better. So what we need to do is, within our system, is we need to routinely do the ABO and RHD grouping, antibody screening, and the cross-match, the mandatory steps that we do. If the blood is required urgently, which it would be, the time of the requirement and nature of emergency should be mentioned in the requisition form. So there should be one person who's actually dealing with this, because these are a lot of documents that you need to fill. And once the patient goes inside and you have already issued, it is very difficult to then go back and fill these forms. Yes, in very urgent case, very urgent cases, uncross match red cells of the same group of the patient can be done. And if you don't know the group of the patient, and if it's male patient, obviously you can give O positive in emergency. And if it is a female patient of childbearing age group, please remember, we need to give O negative units. We don't want to expose O positive to a women of childbearing age group who might turn out to be Rh negative later. So yes, O uncrossed O red cell can be given to the patient, but remembering that for females of childbearing age group, you need to give O positive, O negative units. So or Rh positive can be given to Rhd negative males and postmenopausal females patient if they do not have Rh antibodies in their blood and Rhd negative is not available. In these cases, when you're giving this, with the consent of the clinician, an uncross-matched blood should be written on the compatibility report and the label of the blood bag. And once you have issued, you can go ahead and do the rest of the testing. Coming to the third part, that is the testing. So what are the initial baseline tests and repeat testing that you need to do? Very important. So once you have this in your protocol, it is very easy. So what you need to do is develop a protocol in which by default you should have these initial baseline tests which should go in one go, like CBC or coags, the electrolytes, the blood gas, the lactate. So these are initial tests which you need to give, and you need to make sure that they are gone. So once you have a protocol, you don't need to think, okay, we have to take just red vial, citrate vial, or suppose EDTA vial, or whatever vials are required for your testing, and just give it there. So this would help that time you are not reinventing the wheel. So you have your initial baseline tests that have been given. After that, every hour you have to give HB, your hemoglobin, your INR, your lactate, your VBG, your fibrinogen, and your temperature. Don't forget, you have to monitor the temperature of the patient every 1 hour. That is very important. Now, why we have highlighted this is these are two tests, that is fibrinogen and calcium, which sometimes may miss. So please remember, please remember that the take home message here is when you are testing, always send for fibrinogen and also calcium. These are very often forgotten. And fibrinogen, why? Because it's the first factor that decreases when you have a bleeding. So fibrinogen goes down, and that is why you need to have your cryoprecipitate ready, or if you have a fibrinogen concentrate, you can give it that also. The other thing is calcium. When you're giving so much of units, many a times with every 3 to 4 units, the calcium, because of the ACD or the anticoagulant that is there, the calcium is chelated and the calcium decreases. So for that, you need to administer calcium every 3 to 4 blood products that are administered, and you can do that only when you start monitoring it. So these two tests, calcium and fibrinogen, needs to be given. Fibrinogen in fact needs to be given every 1 hour. The temperature monitoring is equally important. The temperature monitoring happens for every hour because there is a condition in which you can have a hypothermia. So when you are giving these units which are 2 to 6 degrees Celsius plus, you are giving these units so often that many a times a hypothermia may happen. Now PTT I have written is an initial baseline test. That is the APTT but it is a one-time screening test. So you don't need to give it again and again. Only if the patient is on DOACs, that is the direct oral anticoagulants, you need to check for it. So otherwise you don't need it. Just send PT-INR. APTT only once. Fibrinogen, of course, needs to be monitored. Coming to the next T, that is tranexamic acid. Very important. It should be given upfront for the trauma patient. It will prevent hyperfibrinolysis, and this should be given within 3 hours. So always remember, if the earlier you give, the better it is. So if you are giving tranexamic acid, so it should be in your protocol in such a way that when the patient comes, giving tranexamic acid should be a dictum. So there are very few contraindications to tranexamic acid. It could be a coronary stent, acute hematuria, or history of venous thromboembolic disease. The other important thing when you are giving tranexamic acid is the dosage. So you have to give 2 times 1 gram dose, or you can give 2 gram IV dose upfront. So I would advise, and depending upon your ER team, that you give 2 gram IV dose upfront. Why? Because many a time you would see that when you give 1 gram dose either as a bolus or as an infusion later, so you would see that sometimes the patient is shifted from here to there in some surgical ICU or somewhere, and you might miss that dose. When you give 2 gram IV dose upfront, it is adequate dose, and you don't have to worry about giving the dose again and again. So depending upon your protocol, what is laid down, you can do that, but idea is to give 2 gram IV dose. So next T is temperature. So hypothermia increases mortality in trauma patient. We all know that. So you need to control this hypothermia. which can result from trauma itself as well as administration of blood products. And this can sometimes be overlooked. I had already emphasized that every 1 hour you need to check the temperature, and you can do some simple maneuvers like removing the wet clothing if the patient is wet, he may be soaked with blood or anything, you can just remove that, give a surgical gown or something, place warm blankets, administer warm IV products, and monitor temperature every 1 hour, more often in patients who present as hypothermia. So you can do that. It is very important. We don't need to miss this. That's why the highlight. Coming to the targets, when do we achieve these targets? So very important in this is the time. So first when you initial test that you give, you need to know that what are the baseline values. Once you have the baseline value, you can see from there how the trajectory moves. So they are not just numbers, you need to see how they are behaving. So suppose your HB is 8 now, and with your resuscitation measures it is increased to 11, 12. Obviously you don't require red cells, and you have to have other targets achieved as well. So you can see that trajectory is going in the right direction. But if your platelet count is suppose say 1 lakh, and by the time you are starting your resuscitation it is already 20,000, obviously it requires platelets to be transfused. The other thing is the total numbers. So time, trajectory, and the total numbers. The total numbers are equally important. You have to have certain target levels, what you want to achieve, and then when you start, calling off the massive hemorrhage protocol. So they can be both hematological and metabolic parameters. So you do need to monitor them both. So you need to have HB, which you're monitoring anyways 1 hourly. You need to have platelet count should be greater than 50,000. Your INR should be 1.8. Fibrinogen should be greater than 150 milligram. So this we very important. You need to see. You can have cryoprecipitate, or you can give a fibrinogen concentrate depending on what you have. The metabolic parameters include pH, which should be greater than 7.3. Lactate should be less than 4, and calcium should be greater than 1.15. So all these numbers actually help you, but it is the clinical judgment in the end when you want to call off the massive hemorrhage protocol. Because once the targets are achieved, and we as a team are equally inclined and uh, occupied in this, and you call off the MHP, then everything is in a sedate mode. So you should be very careful when you call that. You can't call off the MHP and say okay, no, now we want to again initiate it. So you have to remember that the targets are very important, and you should not over or underdo it. So these are the safe limits of HB and COG factors. So HB should be greater than 10. It is the target value that you want to achieve. It is, 7 is okay, but if you achieve 10, it is very good. Platelet count should be greater than 50,000. PT less than 1.5. APTT, which we do it only once, less than 1.5, and fibrinogen should be at least greater than 0.8, but best is to have greater than 1.5 gram. So when do you terminate the MHP? So it is a dilemma. It is a very it's a conscious effort which should be done in a multidisciplinary fashion. The decision to stop MHP is nuanced and based on both hemodynamic and resuscitation target which have been outlined. It is important to involve the ED, the inpatient teams, and also inform the blood bank, because the blood bank technicians have left everything. They are just concentrating on one section of the blood bank is just occupied in the massive hemorrhage protocol. So the general requirement for termination include normalizing the hematological and metabolic parameter and also the hemodynamic pattern. So you need to clinically judge whether you require to terminate the MHP or you don't require it. So this is the usual thing that we perform. So usual preparation of massive transfusion protocol pack comprises of FFP, PRC, RDP in ratio of 2:1:1 with 1 pack of cryoprecipitate, where 1 pack of cryoprecipitate is 5 cryoprecipitate urine. So this you can have this as 1:1:1 or 2:1:1 depending upon what your protocol says. So we have both the teams which are actionable, the clinical team and the blood bank team. So we, as a blood bank team, you need to initiate the box. Your box should comprises of the products in this ratio. You can have 666 depending upon what you want to give in initially, or you can have 2:1:1 where you can have 4 red cells, 8 FFP and 4 RDP or 1 STP. So this is what you do as a blood bank team. You make it ready, you have to thaw it, and you have to very consciously make sure that your products are ready. So once they are ready, they need to be issued. There should be good coordination. The the blood bank needs to inform the treating team that the first round of this box is ready. first box is released as soon as possible, and then as soon as it is released, the blood bank needs to start preparing the second box, and the second box will also have the same kind of uh, units. Then the blood bank will inform that the next round of component is ready. So whenever it is ready, you have to inform it that it is ready and it is ready for issue. And this, even if you have to take your box and run to the OT, it is okay. It doesn't matter, your ego is not important here. Saving the patient's life is more important. So whether it's a clinician or a housekeeping or anybody who is equally inclined can take the box to the OT, obviously with the compatibility and everything, and it is given to the clinician team who is going to prepare it to be. So unless specified, blood bank releases prepare box of the component and ceases preparation of future boxes. So treating doctor will inform the blood bank and stop the MTP if hemostasis has been achieved or the patient has succumbed. And then the MTP or a massive hemorrhage protocol is discontinued and unused components are returned to blood bank or not or used depending upon your policy. So only when you get a call which has to be documented can you discontinue the massive hemorrhage protocol. So what are the special consideration in massive hemorrhage protocol? This is a very ideal scenario that I discussed till now, but there can be smaller hospital with challenging access to blood product. They may not have blood products. They may not have one product over another. They may not have O negatives or O positive, depending upon what kind of an inventory you are maintaining. So these hospitals, you will face the challenge, but good thing is you can start using the products like PCC, that is the prothrombin complex concentrates, or fibrinogen concentrate if they are available. Even if you don't have blood products, these products are very important because PCC, if you see, contains factor 2, 7, 9, 10 vitamin K dependent factors like 2, 7, 9, 10 along with protein C and protein S. So once you have PCC, you have actually given what FFP would give. At least vitamin K dependent factors are there. Then fibrinogen is there. You can give fibrinogen because fibrinogen is very important and it is the first factor that gets reduced. Sometimes the patient may have a life-threatening hemorrhage, maybe on direct oral anticoagulants, so you need to reverse them. You have some anti-reversal agents available, or you can use other factors, but keep into account that the history is very important, that patient is on direct oral anticoagulants or not. In OPS patient, you should know that the cryoprecipitate needs to be given in a higher quantity because you need to ensure that the fibrinogen level is more than 200 milligram per deciliter. It's not 150, it is 200 in OPS patient. So all the more important that you give cryoprecipitate in case of life-threatening hemorrhage in OPS patients. So replacement of fibrinogen may decrease both the need for ongoing blood transfusion and associated complications such as volume overload. Then blood product stewardship is equally important. The blood is a precious product. It's not a tonic. You can't use it's not to boost your energy or anything. It is required in some special situations. So if you call off the massive hemorrhage protocol, it will help blood bank to not overthaw units for FFP, to not over cross match or not over issue the unit. So that is also equally important, that when to terminate the massive hemorrhage protocol. Sometimes we are so overwhelmed that we might not inform the blood bank, and that is where we as transfusion medicine are constantly making these boxes till the time you call off this massive hemorrhage protocol. There are complications which are associated with blood transfusion, which can be acute and chronic. It is the usual complications like trali, taco, citrate toxicity, hypothermia. So once you give product, obviously there will be some kind of a complication. So we don't need to get into this, but please remember blood transfusion is associated with some complications. So the take home message for the 70s of massive hemorrhage: have a formalized MHP in your institution. Time is life. Every 1 minute delay for receiving first packed red cell is associated with 5% increase in mortality. So you need to do it early and give it fast. The trigger for MHP should take into account clinical details. Fibrinogen, very important, you may miss it. So fibrinogen, always remember, it should be a part of your protocol, and it's the first coagulation factor to drop in trauma. Patients in whom MHP is activated tend to develop hypocalcemia, so you need to monitor the serum calcium level and replace calcium accordingly. Do not neglect to keep the patient warm by monitoring temperature, remove wet clothing, etc. Hypothermia is a complication, you need to see that. Tranexamic acid should be administered every 3 hours. Within 3 hours of the injury, it has a significant mortality benefit, and 2-gram dose is better. And termination of MHP is shared decision, which is among the emergency doctors. blood bank, clinicians, surgeons, and whoever is dealing with the patients. These are the references that I've taken into this massive hemorrhage protocol. So thank you so much. I hope you have understood what needs to be done in this massive hemorrhage protocol, the importance of transfusion medicine in this, and the importance of cohesiveness and interaction and good communication between the transfusion medicine and the clinical team who is operating for these patients who have got these trauma-induced bleeding and coagulopathy. So anything you have not understood in this lecture or you want to discuss again or you want me to elaborate on something, please write in the comments. We are happy to answer in those and also suggest which new lecture we need to take. Thank you so much. Hope it was beneficial to you and happy learning. Thank you so much.